want to talk about what we can do as providers, what we can do as dental assistants and dental hygienists, and what we can do in the industry to help people. How can you make it easy for people to say yes to your treatment plans? That's what we're going to talk about today. And I want to start with kind of some history of this. I graduated University of Illinois in 1975, went into the United States Navy. From there, I had just a terrific experience with Dr. Dawson's courses down in St. Petersburg, the Pankey Institute. Carl Misch and I became friends very early in our career. I placed my first dental implant in 1978. I believe it was 1979, it became legal and ethical for professionals to market their practice. Well, back then it was kind of unthinkable to do implants, and it was even more unthinkable to do dental advertising. Remember those days? Well, I hired a PR firm, and we, by 1983, our practice was exclusive to implant and restorative dentistry. I had such a good time in dentistry. By 1984, 1985, I had served at all levels of officership of the Southern Academy of Implant Dentistry. Actually, I placed my first dental implant in a little city just north of here, Port Charlotte, Florida. I'm curious, does anybody in the room know Dr. Harold Robbins? Harold has passed, but does anyone know Harold or his daughter Rosalie? Well, I met Harold up in Boston at one of my first CE courses. And Harold is a terrific guy. He said, come on down to Florida, we'll start doing some implants. Well, I placed my first implant there. We got really involved. We started to market the implant. By 1983, my practice was exclusive to implant and restorative dentistry. And we had a full commercial lab in our office. I had the television cameras in the operatories. We brought students up, showed them how to do the surgeries, got really, really excited. Then in 1993, this is fast forward now, 1993, 18 years into practice, I woke up and my right eye was crossed to the midline. Literally. I was born with crossed eyes. I was very ugly as a baby. I have pictures to prove it, okay? My brother Guy would tie pork chops around my neck so the dog would play with me. It was that bad, okay? I went to the eye surgeon and he said, the convergence from working closely, doing the surgery, has caused this muscle to relapse, and that was the problem, muscular problem. He said, we can fix it. He said, it'll probably relapse it again, but we can't fix it a third time. He said, you need to find another job. Well, right, how would you like to hear that? I mean, I'm 18 years into it. I'm 43 years old. I'm right at the top of my game. And I got some eye surgeon telling me I need plan B. I'm thinking, hey, buddy, take a hike. So I had the surgery and went back to practice a year later. Bang. Crossed again. Well, I went back for surgery a second time, but then instead of going back to practice, I took a for sale sign and I pounded it into the ground in front of my office. Right at the prime, when I was really on the top of my game. Well, I had a lot of friends that said, well, what are you going to do? And they said, well, Hama, you're so full of it. Why don't you become an attorney? And I thought, no, I love dentistry. I'm going to stay in dentistry. So I decided to innovate something in dentistry that I thought really needed some help. You see, what really got me excited about dentistry, particularly dental implants, was the newness of it. It was that innovation. It was that creativity that I really loved. And Bradley is doing the same thing with the internet. It's a new thing, isn't it? And it's exciting. And it provides the juice. And and I love that about dentistry. And I thought, well, what's in dentistry now that needs some juice? I decided to focus on the issue of leadership. Right? Leadership. You may say, well, why leadership? Well, leadership, you see, is the missing link that most of us need to really get to another level. Let me show you what I mean. Typically, dental practices grow pretty quickly. The horizontal axis represents your career. The vertical axis represents your relative level of success. And generally speaking, the first 5 to 8 years, practices grow fairly rapidly, right? But then something happens at about year 8, 10, 12, somewhere in there, that the practice growth levels out. It's not that we're not successful anymore, or we're successful, but the rate of growth has slowed down. And the reason that practices slow down is because as we get more successful, the level of complexity in the practice increases. You see, this is one thing that practice management specialists will never talk about. Everybody wants to grow the practice, right? Right? You go to the meetings, people will say, hey, do this and your practice will grow. Do this and your practice will grow. Hire some more people. Bring in dental implants. Get a CEREC machine. But you know what folks don't tell you is that every time your practice grows, what happens is you add another level of complexity to it. My practice was real simple when I had 3 staff members, right? Very simple. I could see one, she was sitting right next to me. Hygienist was right across the hall, I could hear her, and all I had to do was lean out the doorway and I could see the receptionist. But then you go from 3 to 5 to 7 to 12, right? And all of a sudden, it gets really, really crazy, right? Rita, the hygienist, she's pregnant one month, not the next. Suzette, your dental assistant, is chewing gum under her mask. It's just crazy, okay? Just nuts. So the complexity increases. You see, complexity is the silent antagonist. Complexity is that unintended consequence that accompanies growth. And what complexity is, it's a kind of an invisible energy that pushes back on your practice. See, each of you has an energy of growth. That is your energy to want to strive and be successful. You have that energy in you. Otherwise, you wouldn't be in this room right now, would you? Well, that energy is antagonized by that energy of complexity, right? And so what happens, your practice will grow to a point to where the complexity equals the amount of growth. And then when you're at this point of equilibrium, no matter how hard you push on your practice will push back. Who knows what I'm talking about, right? We all experience that. This is a very typical business phenomena. I'm experiencing it in my business right now. My single greatest issue of complexity in my business right now is travel. For every hour I teach in front of the room, I'll spend 3 to 4 hours in travel. So I have about a 3-to-1 or 4-to-1 ratio in teaching to travel. That's an enormous amount of complexity. And all you got to do is the mathematics on this and discover that I have a plateau, that I have a limit to how many places I can go and speak, okay? Well, you have an issue of complexity too, don't you? And today I want to talk about the single most prevalent issue of complexity that holds us back in our practice. Before I get to that though, I want to complete this. What most practitioners will do, whoops, we got an issue here. There we go. What most practitioners will do, and I did the same thing. Remember, I practiced for 20 years. My first 10 years were much different than my second 10 years. The first 10 years I spent making all the mistakes. The second 10 years, I think I figured something out. And what's been interesting is I've been out of dentistry. I've been out of active clinical practice for 16 years. And I know now more about the practice of dentistry. I'm talking about the management and the leadership aspects. I know more now than I ever did when I was in practice. Why? Because I've got time to think now, okay? I got time to think. You see, when you're in practice, you don't have time to think. I didn't. I'd walk into my door and have 11 staff members like piranhas on me. Right? Read this, go here, right? You got to see this patient, you got to do this. I'd go into the John to hide from them, right? Get away from these people. Right? Last 16 years, I've been able to go all over the country and see the best and kind of think it through. And what today is about is what I see that works really well and what I see that's not working. Here's what's not working for most dentists, is that as you get to that plateau and you begin to feel it, the instinct is to take more clinical continuing education. Because remember, that's how you got to be successful in the first place. You took a course in implants, you took a course in bonding, you took a course on occlusion, right? That made you a little bit more successful. But you reach a point to where you know enough. Now, I'm not saying that you should stop studying. I'm not saying that. But what I'm saying is that when you're on the plateau, for most of us, who've been in practice 10, 15 years, come on, you got it, you know it. Any incremental gain in clinical continuing education certainly will be helpful, but it isn't going to be the long lever arm in your career like it used to be. And what many general practitioners will do is they'll go back into the clinical arena, bring more stuff into their practice. For example, let's say you're a general practitioner, and let's say you have collections of $800,000 a year. Let's just say that, okay? And you wake up one day and you go, you know what, I got to get to the next level here. I'm really going to kick the doors out. I'm really going to make something in my practice. So you run off to one of my favorite places, the Misch Institute, to study with Carl Misch dental implants. You go to the Misch Institute and you come back and you're just filled with the Holy Spirit on this thing. I mean, you're really psyched, right? And you got new hand pieces and you got implant body parts and you got this and you got that and you're really excited, right? And you bring all this stuff home and you give it to your dental assistant, bang, right there. Here, figure this stuff out. Right. Now let me ask you something. Does bringing dental implants into a general practice add to or reduce the level of complexity in that practice? It adds to it. How much? A lot. Now, am I saying not to do dental implants? Absolutely not. I'm not saying that. What I'm saying that is that every time you make a clinical decision, every time you go to a clinical course, you are adding complexity to a practice that's already stalled. That will create stress, okay? And the reason I want to emphasize stress right now, because see, stress is the killer. Stress is what stops us. Stress is when you as a person, and I'm talking to everybody in the room right now, stress is when you as a person are your least authentic self. People can sense it when you're stressed. So, what we want to do is eliminate complexity, okay? And there's a word for that. The word is called leadership. Remember 5 minutes ago I said when I left the clinical practice I decided to focus on one thing, and that one thing would be leadership? See, leadership is the antidote to complexity. Leadership is the management of people, money, and time. Leadership is the way that you can make it easy for people around you to succeed and feel better about themselves in the process. Leadership is going to be the way that we're going to combat stress. Now, what I want to do is take leadership, which is a very broad topic, and what I want to do is I want to narrow it down to one specific thing that you're doing in your practice that is responsible for more complexity than any other process you have, and that is the case acceptance process. The case acceptance process is responsible for more complexity than anything else in your office. Let me show you some things. We'll back up to this. Last slide on this. Oops, does this back up? There are generally two growth curves in dentistry that we experience. The first growth curve, as I've described earlier, is the clinical phase. Our practice grows based on our ability to manifest our clinical skills, our hand-eye coordination, our speed, our ability to get around in the mouth, our ability to deal with patients. That's that first growth curve. That first growth curve will lead you to that plateau, okay? Now, the second growth curve is all about reduction of complexity. Once you understand the mouth, once you understand how to deal with the dental materials, the patients, the devices, and the technology, that second growth curve I label the leadership curve. The leadership curve is where you understand how to fix the teeth. The leadership curve is all about making your practice profitable, less stress, and able to grow again. That's the second growth curve. And when I look around the room, I see some more seasoned practitioners in the room. And I think that a lot of you can kind of feel what I'm saying right now, is that the way up is not by taking another course in cosmetics or implants or occlusion. The way up, the lever, is going to be through your ability to communicate better, listen better, lead people, manage money and time better. That's where the lever arm is. And again, I'm not saying stop taking clinical continuing education. I didn't say that. What I said is that if you're going to take clinical continuing education, think about taking some companion work relative to leadership. And that's why I'm here today. That's why Bradley asked me to be the first speaker in this series, is that everyone who comes after me in this series, who's a clinical speaker, speakers who are going to bring to you a plethora of knowledge and information, if that information is not accompanied with a strong dose of leadership, what ultimately can happen is that you can get overwhelmed with technology and your practice not budge a bit. Okay? So, let's look at case acceptance. Now, I don't know if this is in your handout or not. I don't think it is. Occasionally, I'll have these visions when I'm in an airplane, you know, at 35,000 feet, right? Airplane is shaking, I get these visions all of a sudden. A little Jack Daniels will help. And occasionally, I'll actually develop some work while I'm in the airplanes, and this is one of them right here. It's a simple graph, and what it shows is that the percentage of case acceptance has, the percentage of case acceptance dramatically goes down as the level of the fee goes up, okay? You see on the graph here that between 1,000 and about 4,000, case acceptance is relatively high, but once that fee goes over $4,000, $5,000, $6,000, it dramatically takes a turn down, and at the $10,000 level, case acceptance approaches zero. Now, when I say case acceptance, what I'm talking about is the patient's willingness to go ahead with treatment within 1 month. That is, the patient hears the treatment plan, understands the financial concerns behind it, and then within 1 month begins treatment. This is what I'm saying with case acceptance. And at the $10,000 level, for most general practices, case acceptance approaches zero, okay? Most practitioners tell me that the $10,000 plus case acceptance for that case is about less than 5% of the time, okay? So, I don't think anyone would argue with this. Raise your hand if this is your experience in your practice. Well, every hand in the room should go up because that's what the truth is. Now, do you know what the word culture means? Culture is when a community of people have shared beliefs and they have a shared language. And those beliefs and those languages basically lead to a common behavior among a population. For example, if you went to Italy, they've got a different language, they've got a different belief system. They behave differently. It's called culture. That's what that word means. Dentistry has a culture. That is, we have a core central belief that drives our behavior. It drives our language, right? And that core belief is that our role is to develop clinical quality. See, clinical quality is at the center of the culture of dentistry. That's what we're about. We hold in very high esteem outstanding clinical results. Also at the center of our culture is the fact that in order for patients to experience that quality, they need to be educated about it. A core belief is that we need to raise our patients' dental IQ. Would you not agree with that? That's what I learned from day one, that we need to educate people as to what's wrong with them and how it got that way and how we can fix it, and then how happy they'll be when it's all done. It's a core belief that we're going to educate people, we're going to change the way they think and how they behave relative to dentistry. It's a core belief. So we have at our center the concept of raising the patient's dental IQ. It is absolutely fundamental in all of our literature, all the dental hygiene schools, all the periodontal training, everything you read and see in journals and in our institutions. At the core of it is we need to raise the patient's dental IQ. It is our tool that we're going to use. Now, when the case is simple, let's say it's a crown and a cleaning and a filling, you don't need to do a lot of educating because you see there's not a lot to educate the patient to. So you might spend maybe 10, 15 minutes with the patient, telling them what's wrong with them and what they need, and here's how we're going to do it. And they go, okay, how much will my insurance pay and how long it will take? That whole dance that you do. Now when the case gets really complicated to where you're doing a mouthful of implants, a mouthful of crown and bridge, you're going to spend a lot more time, aren't you, in raising that patient's dental IQ. As a matter of fact, the more complex the case is, the more you're going to raise that patient's dental IQ, the more time and complexity you're going to invest in that patient. This is based on our core belief, our core culture in dentistry, that our role is to raise the patient's dental IQ. Now, if raising the patient's dental IQ was the key to case acceptance, then why does the case acceptance curve go down in the presence of us providing the most amount of patient education? If patient education was the key to case acceptance, then the case acceptance curve should go up, but it doesn't. That leads me to believe that maybe raising the patient's dental IQ is not the tool of choice relative to case acceptance for complex care dentistry. Now, what I just did is kind of broke one of the core values, didn't I? I kind of said to you, well, what you've been doing probably isn't right. Well, I don't mean to come in here and make you wrong about what you're doing. But I can tell you that the case acceptance process, especially for the patient whose case fee is greater than $10,000, is a much different type of conversation than the case where the case fee is less than $1,000. And that we have two separate, completely different conversations relative to the case acceptance process. What today is about is how do we now talk to patients who have got extraordinary dental needs? How do we talk to them in such a way that they'll get it? Secondly, I want to teach you some things to where the case acceptance process has less complexity attached to it. The less complexity that's attached to it, the more energy that you'll have for other activities in your life, for other patients. So, here's what I'd like for you to do right now. I'd like for you to look at this slide. I don't think I have it in here, do I? No. That's another one of those airplane phenomena, okay? Why don't you draw it right now? Take a second to draw it. And I want you to take a minute or so, and I want you to talk to the people who are at your table about this slide, where it shows that you're spending more time educating people, but you're experiencing a lower level of case acceptance. I want you to talk about that. Is this true for you? How does this make you feel when you see it?
Buy things with emotion.
Sew them in.
Yeah, because not what we want.
I bought this tie on emotion.
Because I wonder.
That's right.
Yeah,
I bought this tie on emotion. I thought it looked good on me.
Yeah.
Well, that will be for the recording.
Emmanuel, the mic's on.
There we go. Put it together for Grace, everybody. Yay.
All right. I was just saying, most of women, we buy things with emotion. I want it. It's not what I need. It's what I want. And in dentistry, I just think the motivation and concern is so important to find out what our patient's motivation, what is their concern. And so that brings us the value, you know. So that's my comment. And he says the men buy things with emotion too.
There's a lot involved with case acceptance up here that's much more than just what's right here. You see, raising the IQ works well here. I want you to think about that. Raising the dental IQ with cases that are more modest in the $1,000 to $2,000 range, that works. Here's why. Because oftentimes these patients have no awareness of their conditions, right? They come in and they say, I just want a cleaning. You look in their mouth, you take a few x-rays, they got interproximal tooth decay, right? They've got periodontal disease, missing teeth. So we spend some time telling them and educating them, there's the word, and showing them what the problems are. They didn't know they had it. They go, oh, I didn't know I had this. So education at the more modest fee level works because oftentimes the patient is not aware of their condition. Now, however, what if this patient comes in, and I'm talking about the patient now who walks into you and says, I hate this. I hate all these teeth. You know, I own a kaleidoscope art gallery right here on the main highway. And this guy comes in, he's a cute guy too, and instead of looking at my artwork, he's staring at my teeth. And I was so embarrassed, and I hate these. Now, how much education does this patient need to the fact that she's got problems with her front teeth? She doesn't need any. You see? And so the consideration or the decision-making process at this level is much more about money, right? Much more about the time involved in their care, much more about the inconvenience. It's much more about what is going on in the patient's life, and it's less about what's going on in the patient's mouth. Here, it's all about what's going on in the patient's mouth. Does that make sense? We had a question right here, and we need the mic. Here we go. This is just for the recording. There you go.
No, I was just going to comment with regard to that curve and what we were talking about is the
Yes.
first part of that curve is exactly what my experience has been. Patients know what they want, the first part. That's why it's high case acceptance.
Sure.
The farther out you go, the more optional it becomes and the more emotion takes part in that. So
Sure.
I think that's why it falls off. They know what they want in the first part. The farther out it goes, the more optional it becomes and the more emotion driven it becomes.
I really like what he said right there, that farther out, let me make sure I got what you said correct. The more you go this way, that is, the more complex the case gets, the more of an emotional decision it becomes. Is that what you're saying?
Right, because it usually is optional.
Right. And the emotion resides around, can I afford it? Should I do this instead of going to Tahiti? Do I do this instead of getting the widescreen TV? I'm thinking about getting the divorce, or I'm thinking about getting married, or I'm thinking about adopting a baby girl. There's a lot of emotional decisions in there, isn't there? Okay? And yet, in this room, we can come to complete agreement on this in a matter of just minutes. But the profession still very much has a stranglehold on the idea that we've got to change the way people think about dentistry, that we need to increase the value of the dentistry in the patient's mind, then they'll want it. And I'm saying that doesn't make any sense at all. If you know anything about adult learning or instructional design, that is how to put together talks, how to teach adults, that education is educating a person to do a task has a very low correlation of them actually doing the task. And there's all sorts of literature in the general business industry about how much training actually gets transferred back to the workplace. Fewer than 10%, less than 10% of what goes on in classrooms actually makes it back to the workplace. Why is that? We educated the people to it. Why don't they do it? Well, the reason they don't do it is because education is not the strongest motivator for people to change. I mean, if education was the reason that people changed, then gosh, we'd all have ideal weight, perfect blood chemistry, and fully funded retirement plans, right? If education was the key to getting people to teeth fixed, well then, I am sure that I could take an Explorer and a Perioprobe and I wouldn't make it past this first row before I found some significant dental disease. You see, you can't change people very easily. That's where our cultural belief gets in our way. We believe that we can change people. That's false. And that is right at the heart of why we have so much complexity in our practice. You think it's easy to change somebody? Marry them.